Okay, sorry for the delay, ladies and gentlemen, a little bit of a technical glitch. And thank you for ladies and gentlemen for joining us today on this Facebook Live information session on the safe and successful school reopening. My name is Drew Ferguson, Public Media Relations Coordinator for the Grey Bruce Health Unit. I'm the moderator for this session. Joining us from Public Health are the Medical Officer of Health, Dr. Ian Ara. Also with us, Lori Wilder, Director of the Blue Water District School Board, and Gary O'Donnell, Director, Bruce Grey Catholic District School Board, for this Facebook Live forum. Following my introduction, the format of the meeting will begin with the brief opening remarks from both of the school board directors, followed by Dr. Ara, who will provide some additional content. We will then address the audience questions. We've received a large number of questions, almost 200. So I've merged as many as I was able to cover into key concerns. And we're also making the message function available on Facebook for you to put forward your questions. Those questions will be sorted and relayed to me as best, and we'll take them as best we can. Some questions were very specific to individual situations and didn't lend themselves to this format. So if we do not answer your questions, please forward them to Public Health through our Contact Us page on our website, and we will respond to all inquiries. That email is publichealth@publichealthgraybruce.on.ca. The health unit, both boards of education and the province have extensive resources available on their website. I urge you to consult those resources for the most up-to-date information. And please note this session is being recorded and will be available on the Grey Bruce Health Unit YouTube channel. A link will be provided as soon as that is available. To get underway, it's my pleasure to introduce Lori Wilder, Director of Blue Water District School Board. Lori.
Thank you, Drew. On behalf of Blue Water District School Board, I would like to extend my sincere thanks to Dr. Ara and the staff at Grey Bruce Public Health for hosting and inviting us to participate in this Facebook Live event. During these challenging and uncertain times, there are understandably many questions that our parents, guardians, and families have as we plan for the safe return to school in September. These types of events are invaluable in facilitating discussion with our stakeholders and ensuring we all have the facts and most up-to-date information during this very fluid situation. As part of our extensive planning this summer, our board has been very fortunate to be able to work closely with Dr. Ara and his public health team. The guidance and ongoing wealth of local data that has been provided by our public health partners has been instrumental in shaping our plan for reopening our schools after several months of closure. It is important to remember that we are all in this together, and we have a shared role in making our school return a safe and successful one. I look forward to this evening's dialogue, and Blue Water District School Board thanks you again for this collaborative opportunity to engage the families we serve in Grey and Bruce counties. Thank you.
Thank you, Ms. Wilder. And now for Bruce Grey Catholic District School Board, Director Gary O'Donnell.
Thank you. Likewise, we want to thank Dr. Ara and the team at Public Health for their support during this pandemic, and for this opportunity to be here today to provide families with as much information as possible before their return to school. I also want to thank our families on behalf of the chair of our board, Lori DeCastri, and our trustees as a whole for your participation and your thoughtful responses in our surveys. They have been most helpful in assisting us along the way as we plan to reopen our Catholic schools. For families who've chosen in-person learning, we want to let families know that we're well underway in preparing our schools for September. Our critical supplies and PPE are arriving, and we're preparing school signage, etc. In terms of PPE, masks, and face shields, hand sanitizers, etc. are already arriving and being sent to our classrooms. For those families choosing distance learning, as a return to school survey has just closed, we are looking at each school and starting to build virtual school classrooms for our elementary school age children. At present, we're looking at class lists. More specific information will be available for those families who choose this model of delivery. Like many school districts in the province, we're using a quadmester approach for in-person learning in our secondary schools. For our secondary school students who have chosen virtual learning, we're in the process of building them timetables that work continues and we will be connecting with our families. Our staff are in the process of starting to return to school to set up their classrooms and getting ready to welcome students. We look forward to the return. Our schools have been quiet since March 13th, and it will be wonderful to hear the voices of our students and our staff echoing throughout our hallways. The theme for our return is reconnect, respect, and respond. We have an intentional focus as we return to school on the mental health and well-being of our students and staff to ensure that they have a safe place to land and are well supported by a caring staff. All of our information is available on our return to school site. Thank you.
Thank you very much, Mr. O'Donnell. And now to take to the matter at hand, stage 2 reopening, or the safest school reopening, a medical officer of health, Dr. Ian Era.
Thank you, Drew. Good evening. Good evening, all. As the medical officer of health for Grey Bruce, I continue to be concerned about the pandemic and the different layers of complexity that it brings for us to tackle as part of the response for this emergency. Despite the concern, I have high level of confidence that we have in our hands all the tools that we need to tackle this situation and iron out the challenges as they come. To start with, I want to thank everybody around the table. Every individual, every family have invested over the past 4 or 5 months, and I have no doubt your investment have saved lives. Lives in your community, lives related to your family or not related to your family. The investment has been paramount and has been augmented with public health investment in providing the appropriate information for the public to be concerned, engaged, informed, but not afraid. And there are 2 other layers to this combination, public health and the public. The support that we have received from the different levels of government, the local political leaders, whether they are municipal or provincial or federal, local political leaders have invested a lot of political commitment into the equation. And political commitment in the training of public health is a term quite used, and I've seen it in different layers during this emergency, has been crystallized in the success that we have seen. Many things happen behind the scene and happen overnight. Otherwise, it would have taken months. And one example would be the recovery centers, the field hospitals. It took less than a day to have the decision made instead of having multiple council meetings. And that's really related to the political commitment. From the provincial level, our local political leaders have done even way more than what people would imagine there is to be invested. The other part of the equation, the 4 pillars I look at, the public health, the public, and the different levels of government, it would be the organizations, local organizations. And in this example, it is the schools. And I can reassure the public, we have been burning the candle at both ends, at both themes, whether it's the schools or public health. And we have been in communication for weeks now to ensure that we have every measure we can in place to ensure safe reopening and to ensure safe return for our kids to have the social interaction they need. The healthcare system is definitely our insurance policy. So far, we have not had any death. We had 2 hospitalization, and we will hope that we keep the insurance policy as insurance policy. It's similar to the auto or home insurance that you buy not with the intention of using, rather in case it is needed. They have been doing an amazing job in providing all the support that we need if there is requirement for quick testing in management of outbreaks and long-term care in hospitals, and their effort has been tremendous. So all of this, just to start with the first point, to thank you. You have invested into this. The success is directly related to the success. The success we have is directly related to the efforts you have put and invested. And I am sure we can continue as a group of stakeholders around the table to provide you with all the information that you need to make the right decisions and see ourselves through this emergency. You look at the situation at hand in Grey Bruce, the epidemiology, it is favorable. We have 0 active cases, and it's very timely to have that confidence in reopening our schools. We have zero death. We have zero death. That's not an easy accomplishment. If you see the numbers from other countries, even the one that's maintained good control over the outbreak, Asian countries, they have done this with extreme dictatorship. We've done it with information and the public being concerned and engaged, like I mentioned. Returning to schools, the situation is again favorable for us to have this step going forward. It is necessary for our kids to have the social interaction they need, the education they need. The school is an indispensable institution we have in our society. And I can give you many examples why it is important, but as a father of one, I know exactly what's needed for my child and how much they're missing if there isn't that social interaction with other kids. And it would be a really great result if we have zero death at the end of the year and zero cases in schools, but it wouldn't be a complete result and complete success if we had multiple depressions in kids, or in the long run, kids failing because of the stress that I have experienced in 2020. So again, opening schools is an important step in the management of the reopening stages, in the recovery stages of a pandemic. And it is worth mentioning, in the mitigation period in March and April, the goal of public health is to shut down everything and put all the measures in place to prevent the transmission, to have the control over the outbreak. And we've done it nicely with the effort of all the people around the table. Going forward in the recovery, like we saw in stage 1 and 2 and 3, it is misconception to think that public health role is to shut everything down. Rather, our goal is the exact opposite, to open as fast as we can, as long as it is safe. And as I said throughout, I have no doubt it is inevitable we're going to see sporadic cases, but if we do our job right, there are not going to be outbreaks. And by we, I mean the collective we, all the partners I mentioned, including the public. So with this in mind, the school reopening is very necessary. And if I can give one more example, the school system is one of the most successful indicators or tools to protect our society from, for example, child abuse or domestic violence. Without that institution, without that interaction, without the multiple layers of good quality service that's invested in the school system, we might miss out on these kids who are suffering in their homes. That's one example of many, many. And there's no need to build a case why we need to open schools. So you look at the role of public health going forward. We will continue to support all partners with the information they need for safe reopening, in reviewing reopening plans, in conducting case management, contact management, and outbreak management. And these are, words you would hear, you would see in the news. Each one of them is a set of robust protocols that would enable us to find the case as early as we can and nip the potential outbreak in the bud. And we've done this over the past 4 months very successfully. The target from the ministry is to contact cases and contacts and to call them within 90% of them within 24 hours. We have maintained a track record of 100% within 24 hours. And if it is high sensitive area or institution like a long-term care or aggregate setting or schools, our response is within minutes. We have robust surveillance systems, passive, active, sentinel, and other types of surveillance. And they have allowed us to ensure that there is no secondary transmission past the first case in contact with the case and contact management, outbreak management. These sets of criteria are in place, or protocols are in place to protect the community, to protect our kids in schools as well. There is a tremendous support from all levels of the system to ensure safe reopening of schools. As you would appreciate, during emergencies, circumstances change. So you would see a guideline going out 6 weeks ago, and another one 4 weeks ago, and another one a couple of weeks ago, and there are going to be more. And this is the norm, and this is the good practice. people might get distracted that why are we changing the guidelines or why the province is. Multiple reasons. The two most important ones are the different consultation that comes from the field, from the hospitals, from the schools, from different partners around the table to ensure the protocols are refined and fit the local need. And the second one that hopefully we'll never see is the change in epidemiology. If the epidemiology changes, we would have to change the strategies and the level of response. All in all, we will continue to provide the public and the partners with the up-to-date information about these regulations and guidelines. What the public can do is the main heavy lifting, and this is universally in this type of emergency in pandemics, to be concerned, to be engaged, to be informed. Those are the three principles for you to ensure you're making the right decisions for your family and for your community. And we'll provide this throughout. Having what I have been calling the 3 W's, washing hands frequently, watching the distance 2 meters and more when feasible, and wearing a mask correctly. These things have been the key in our success for the past 5 months. And they're going to be key in protecting our kids in our community going forward. And I know right now, a couple of you, or many of you, would be thinking, well, we didn't use masks early on. We used them. They were so big, they were our houses. In March and April, when there was a shutdown, everybody was exercising extreme social distancing. So it will be futile to wear a mask because our houses were our masks. In the reopening stages, and especially in the third one, where the high contact and high risk stage it is, that's where recommending the mask use would be appropriate. And that's when we pulled the trigger on it with other jurisdiction in Ontario. And as you can see, the number of cases have actually went down a bit after that intervention. Is it the silver bullet? No, but it is an added layer of protection. And again, these 3 things, 3 W's, are what we all need to hammer for ourselves, our kids, to protect the collective of us. And again, I have no doubt your efforts in the past 4 months have saved lives. And all of us, we need to be proud of this, and we continue to be working on this. It's worth mentioning as a final remark to this opening is we're not out of the woods yet. It's not the time to lower our guard. Pandemics, the way they are very similar to gravity. They don't let go. As soon as there is lapse in judgment, there is a potential of transmission. And this is the experience in many countries, including New Zealand, that is an island, has been successful, has been very successful in preventing transmission. Recently, again, in one of the incidents, there were over 100 cases in the recent future, just from one case in a poster child country. Again, we need to be concerned. We have the tools to go forward, and I am confident we will be able to provide all of us around the table the best for our kids to have safe reopening.
Thank you, Dr. Ara. We'll get into the question session now. And I have to say, by far, the most common question related to what happens if a child in a school tests positive. What are the implications for the child's family, other students and teachers in the class, for the school itself, for the school bus or buses the child takes, including the drivers, and before and after school programs, that whole litany of possible contacts.
So when you hear about a case, there are a few things that already happened, and one of them is transmission 2 weeks ago. When we diagnose any case, that means there is an incubation period in that individual for a period of 7 to 14 days. Then there are some symptoms, then there was a lab that came back after. So 2 to 3 weeks, that's a lapse in time. When the case is diagnosed, by definition, the person had a test 2-3 days ago, and they have been in isolation. And we know that the virus survives on surfaces for less than 24 hours. So if that child had already left the class 3 days ago, there is no need to go and disinfect the whole class and school. And that happened a couple times in some of these investigations that we had, 127 cases, 127 investigations, whether it was in a workplace or a restaurant or others. It's a very similar protocol to the school. We found that some people went and shut down the restaurant and start cleaning, and that's really futile. Cleaning needs to be done, and it will be done throughout before the case was diagnosed. It's a very complex question and requires complex answer, so bear with me. So if we don't have to worry about shutting the class because of the diagnosis, we might shut it for a different reason, but for finding the diagnosis, many parents might have the anxiety to go and say, we need to clean everything. No, we don't. The virus has already been destroyed. When there is a diagnosis under the Health Promotion and Protection Act, the legal framework we operate under in public health, by definition, the lab has to send the diagnosis to the medical officer of health. And the medical officer of health, if used in this discussion, it's not the he or the she, it is the position, it's the authority. We would receive it as a team here before anybody else. We will contact that case, in this case, a student or their family, and we will provide them with the diagnosis and all the support that they need, and the recommendation to be tested as a family or a close contact. We make these decisions swiftly and based on a thorough assessment. So it's swiftly in time. However, we take a complete history of the case, of where they have been and who they have contacted. We will work immediately with our partners, the school officials, to identify who has been exposed and what's the level of exposure. And that's, again, it's not a simple answer and will never be a simple answer. However, it's a straightforward, robust protocol, and it is a conservative protocol in a way that we do not take risk. If there is a suspect of potential transmission, we're going to isolate the person and ask them to be tested. However, not everybody's going to be tested because not everybody's going to have risk. And the general rule in this case, if you hear of a case in the school where your kid is, the general rule that's going to always work, if you did not receive a call from public health, that's a really good day. That means your kid and your family did not have enough risk for the call. If there is slightest risk, you're going to receive a call from us, and you'll be directed to either monitor for symptoms or be tested and isolate. Testing everybody in the class or the school or everybody without symptoms is not a good practice. It's not a good science, and it's unnecessary. And I can give an example here, although it's going to make the answer a bit longer, but it is essential. One of the investigation we dealt with was in one of the 3 hospitals we have in Grey Bruce. There were 2 cases, and potential transmission would have been there. One in a healthcare worker, one in a child, in a less than 1 year child. When we worked with the hospital, they immediately provided us with the potential contact, the people who work on the ward or the patient who might have been exposed. Out of the 70 people who could have been exposed, we tested 0 because there was no need for testing. Out of the 25 in the other department, we tested 7 because they needed to be tested. Now, with the luxury of time, we look back 2 months, there has not been any positive case in the ones that we didn't test, or their contacts, or their families. So these decisions, these protocols are very conservative. We don't take risk, but at the same time, don't expect that everybody needs to be tested. Testing a person without symptom is not a good practice and potentially is harmful, and harmful on different levels. One of them is potential for false positives. The other one is cluttering the system with tests that are not needed. Anybody who needs to be tested, they need to be held in isolation for 14 days or until the test comes back if they refuse testing for 14 days. So you put it all together, if everybody's going to be tested, that means all schools, classes might be shut, as simple as that. And that's not the better practice. And we're not doing this to avoid testing. There is, as you know, capacity for testing that is unlimited. So that's regarding to testing if there is a case. We will contact these individuals, the family, the school, and point out to the people who need to be tested and isolation to be isolated. If we need to test everybody in the class and close the class, we would. If there is a need to test the whole school and close the whole school, we would. But that will be very exceptional. That's not the norm. And I can reassure people, for example, New Zealand, Taiwan had reopening of school with 0 cases, 0 cases. So it is, not unheard of to have these prevention protocols, cleaning and disinfection and screening before kids are sent to school to be screened by their parents for symptoms. Those things are the effective ones. If there is a case, that means the transmission happened 15 days ago. There is no need to panic. The other scenario that's very similar to this one, and just marrying them together with them as separate in their healthcare provider or the assessment center. And in that case, the goal is to rule it out. And if it's strep throat could be tested, that will be a good day. We close it. The person stays home until they recover to come back. If the person refused testing, we will have to ask that kid to stay home for 14 days and their families for 14 days. And we'll assess the risk in the class. Again, we treat it as suspect case, as a probable case, exactly like confirmed case. There is no need, again, if you hear of somebody with symptoms in the school or a rumor of a case or an actual case, for many people to run to the assessment center and require tests on their own. Again, that is not going to change the outcome of the situation. Drew, I don't know if I answered all parts of the question. There was part about the school buses as well.
Yeah, I think you covered it quite well. Basically, we're looking at the various implications across the full engagement of the child, from the family, the class, the school, those that were beyond school buses with the child, and then the before and after school programs that many children attend. So I think they all are covered by your response, I think. I'll move on to the next question, is the screening. And there's a series of questions that ask pre-screening to go into the school. And many kids have the typical runny noses, coughs, allergies, cold-like symptoms, and what you have. And they're particularly abundant in September when they all come back to school. How is that screening process going to differentiate all of these other coughs and runny noses from COVID?
So as I mentioned, we need to be very conservative in this. The screening by definition is designed to catch way more than the cases. Everybody who has symptoms related to COVID, which could be a runny nose like common cold or influenza, would have exactly the same symptoms. So if the person has these symptoms, they need to be cleared by a healthcare provider that this is not COVID. Otherwise, they need to be tested. And if they refuse testing for whatever reason it is, they need to be treated as a COVID case and isolate for 14 days. And this is, again, with kids, we take no risk. And with the individual who deal with kids, some of them might have vulnerability. The community itself might be affected. And in all, these protocols would be conservative to rule out potential cases before they become cases or they transmit disease.
Should a child recover within 24 hours, that might indicate just a temporary thing. Would that child be able to return to school?
Again, that's a question that needs to be answered by the healthcare provider for the kid. If it is runny nose because of allergies that are known and you can prove it and you can attest with high probability it's the case, that person could return. However, if somebody left the school because they are sick, or they didn't go to school because they're sick and they recovered after 2 days, there is a potential, there is a possibility. This is COVID, and the person recovered in 2 days. However, we know that there is potential of infection and transmission for 14 days. And that's, again, the conservative number. Usually most people would stop shedding after 10 days. Having those extra 4 days just to ensure that the very few people who might be shedding will stop shedding.
Okay, I'm going to move on to masks. A lot of questions about masks, particularly why the younger children aren't wearing masks.
So the recommendation from CDC Atlanta, Center of Disease Control, one of the most credible public health agencies in the world, is not to mandate masks in schools, rather to strongly recommend, to encourage. And that is because wearing a mask, to be effective, a person has to be reliable enough to put it the right way and keep it the right way. If you go with younger kids, the younger they are, the less reliable they are to actually use it in an appropriate way. They might be touching their face quite often, increasing the risk of transmitting something to themselves or to others if they carry that disease. The other part of it is the ability to maintain it with comfort. The younger kids just cannot tolerate it. My daughter is 3 years old, and she's excited about wearing a mask whenever she sees a mask. But again, she puts it on, and in 5 minutes, you can find the mask anywhere but her face. So all in all, when you look at the requirement in school for masks, it is encouraged. Older kids can use it. The younger kids might not. At the end of the day, if you look at the hierarchy of evidence, how protective the intervention is, wearing a mask in public places, it is actually about 5 to 12% effective. It's the least effective of the measures we have. Top that list would be the physical distancing, the 2 meters or to the best of your ability to be separate from somebody else. The second one is the engineering solutions. And engineering solution, one example would be the shields that you would see in grocery stores. The third one is a policy solution, administration solution. Policies that would ensure cleaning of a school would be at night, so there are no interaction between people during the cleaning. And I reference this to Johns Hopkins, again, one of the most credible public health medical schools in the States. And that's established for COVID as well, and other infectious disease that are transmitted similar to COVID. So you put this evidence back with the requirement for masks in schools. At the end of the day, if kids didn't wear it, if not all of them wore a mask, it's not the end of the world. It's just an added layer, 5 to 10% extra protection. And if 80% of the kids wear it, that will be optimal. Similar to what we saw in the past few weeks in Gray and Bruce with mandating masks with an order, we implemented so many exemptions in it because it is meant to be educational order. It's meant to be raising the awareness of the public to this intervention, similar to using helmet when somebody's riding a bicycle. We don't intend to enforce it. There is no police cruiser chasing every person on a bicycle without a helmet. Similarly, using a mask will increase the compliance if we put it as an order, if we raise the awareness of it, and it has been optimal. And I have no reason to believe that it wouldn't be optimal in schools. If kids didn't want to wear it, some of them, that's not the end of the world. And if more people wear it, that will be added benefit. At the end of the day, it's one fraction of many things that are put in place. And again, I can attest firsthand to the amount of rigor that has been exercised by the school officials throughout Gray and Bruce. There are a certain level of control that's required, and it's always over and beyond the expectations that we would find in these plans. And again, all this to have a safe reopening for schools, including having masks, whether they're used completely or not.
Thank you. And you're actually, your answer included the second part of my question, was the request by parents, would there be a provision for exemptions? And you've clearly outlined that as well.
If I may add on that part, Drew, I don't profess to read the future and know the next question, but throughout all the guidelines that came from the ministry so far, there is no word mandate. There are required, strongly recommended, encouraged, mandating masks. Again, to my delight, the guidelines is consistent with the evidence. Whether it's required after third grade and up, it's still, there are so many exemptions built in to meet the need for the kids at their age and their level of understanding and their comfort.
I'm going to follow up with a question with regard to busing. That was quite a common question as well. Can you address the concerns regarding any risk associated with busing, where we see situations of upwards of 70 students on a bus, up to 3 to a seat, ventilation limited to opening windows, and multiple transfers, including Catholic and Blue Water boards sharing buses? It would seem these factors are all high risk and unable to meet the physical distancing protocols.
I am concerned about every part of the emergency, about every activity, and it is my duty as a physician and my oath to serve the patient I have in this case, in this specialty, is the community. I have concern about every activity. And I just, in general, I want to reassure the public, the parents, the workers, the school staff, and the bus drivers. Every effort is put in place to ensure safety. And if something is not safe or risky, it will not be approved. As simple as that. And I can go in details. I share the concern just because it's a more complex environment. It is many kids in a limited space, as you rightly said, Drew, and the question mentioned less ventilation. However, if you look at it all in all, there are measures in place. One, the screening that happened before kids went from their home to the school. That is key. That is key. Many people think that we need to test everybody before going to school. Again, there is no evidence to that to reduce the risk of transmission, because all that test means that on the day I took the test, I was not shedding the virus. I could be shedding the very next day. And there has been examples of this. If you look at the screening before going to school, that is key. You look at the epidemiology we have in the area, and again, that's effort from everybody, is very favorable. There is increased hand washing during the school time. There are hand washing stations in high traffic areas and where they are needed. Disinfection of the bus between uses is another layer. Having the seat behind the driver empty is, again, that guarantees that 2 meters or a bit more, even if there isn't added shields around. You put all these things, the risk for a driver of a bus is controllable, is acceptable. The fact that if there is one case on that bus, that doesn't mean that everybody's going to be infected. We know that the maximum that's going to happen is the person beside them, the person in front of them, the person behind them. If that kid was very young and was touching everybody and coughing on everybody, of course, if there is any symptom, you're going to exclude them. So this only scenario would be is touching, and that's traceable. And again, is there risk for the driver in that bus if there is a kid 15 meters behind or 3 meters or 2 meters behind? I can sit in this office and I have a Kleenex with COVID on it for 3 days. It's going to be destroyed after 24 hours. And if it happened to be renewed the whole week, if I don't touch it and touch my face, it's not going to infect me. Hand washing of everybody, even the driver, at all times or possible times, will be the key measure to preventing disease. You put all these things in place, I am cautiously optimistic we're going to go through reopening of schools similar to what we have seen in stage 1 reopening, stage 2, stage 3. Hopefully, we're not going to see cases. I have no doubt we will see cases in the community, possibly the school, but that doesn't mean the transmission happened in the school. And to my delight, recent guidelines that came from the province, the definition of outbreak in a school, my understanding, I haven't read it, I heard about it, that it came out early this afternoon, that the definition of outbreak is transmission that happened within the school, which means 2 cases linked to each other. And again, I have no doubt we will see cases going forward, but at the same time, I have full confidence we will control the transmission and nip it in the bud.
Thank you, Dr. Ara. I'm going to move to the area of mental health. A lot of questions with regard to student anxiety and how it's being addressed with respect to how students will cope with the single class all day in the senior schools, and in the junior schools, the young children trying to limiting engagement. So this sort of sets up a new mindset that is not what was the typical school pattern before. I wonder if you can address the mental health aspects.
Well, again, Drew, as I mentioned, the 2 main goals in reopening is to reduce disease and death from 2 sides. One from COVID cases, the second one from disorders and diseases related to COVID measures, whether it's mental health and the pressure, the stress that would come from closure and limitation, or from domestic violence, or from income. And again, some people might say, like, why is this physician talking about income? Guaranteed, if anybody Googles public health agency and social determinant of health, what determines the health of the public, you will find top that list income. It's actually one of the 13 determinant of health, according to the Public Health Agency of Canada. It's part of the training that I had for 5 years as public health specialist, medical officer of health, is to ensure the health of the public, and income is the main one. And in measures against COVID or closure of schools, you're going to find that, well, you can reduce the risk of transmission. However, if there's a family of 2 parents and one of the 2 parents stayed home with the kids and lost their job, the effect on that family, income-wise and mental health-wise, it's going to be for 5-10 years until a person is able to, struggle with no income for a few years and the ability to go back to work. So it would not do it justice if we close everything. And if you go back to the question, mental health for kids is essential. It's a trade-off. How much can we open and still not risk the transmission of disease? Walking that line, that fine line, is what we're trying to do. And again, it will be optimal going forward and finding no cases and trying to loosen those measures a little bit and adding more socialization. However, at this point, this is the appropriate direction for all of us to go forward with. And we continue to monitor closely all the indicators that we need. It is a modified normality. We cannot go back to normality and have all the socialization that we need before we have the herd immunity, which is the silver bullet we are looking for. And hopefully it's going to happen through a vaccine. And I'll be more than happy to add more information of the potential of vaccine in the near future if one of the questions requires it.
Drew, if I can step in, we have a focus on mental health and wellness through our plan, and it's fairly well laid out on our site with a focus on social emotional learning. So families are looking for what are things that we're going to be doing in classes, in schools with their staff and our students. They can just navigate, and it's a section called Learning Services, Faith and Wellness on our site. And it'll detail the work that our social workers and our child and youth workers are doing to support our teachers and support our students. So we have a fairly comprehensive plan there around reconnecting and building positive relationships, supporting a growth mindset, focusing on structures and routines, all through the lens of social emotional learning. So it's fairly comprehensive work that we're undertaking.
Yeah, you beat me to the punch, Mr. O'Donnell. I was going to ask both the directors to comment on that. So, Ms. Wilder, if you want to comment from the Blue Water perspective.
Thank you, Drew. In addition, we have the same in Blue Water District School Board as was just described for Bruce Grey Catholic. And along with that, just to know that both of our boards have mental health workers in place, paraprofessionals and other professionals, staff who remain available to support students. So those are supports that they wouldn't have if they didn't return to school. We have students' mental health as one of our top priorities, and we will do all that we can to support that.
Thank you very much, Ms. Wilder. I've got some random questions here too that aren't under any of the typical categories, but one is, why can my kids play on the public playgrounds but not the school playgrounds?
So risk-wise, it's the same risk, and I don't know if there is limitation to the using playground in schools. If it is coming from the province, I haven't seen that in the guidelines so far. And if it is coming, there would be a reason for it to, based on the assessment for the whole province. In Grey Bruce, I would not recommend to limit using playgrounds as long as there are certain measures in place, like hand washing before or during the activity, and appropriate disinfection, appropriate distance between people who use, kids who use these facilities. Again, this question comes with the presumption that this is limited or not allowed, and I don't know if the school officials would have received something to that effect before we have received it.
If I may comment, we are at this point focusing on the reopening inside the building with the intention to evaluate as we go forward the outside play structures. Right now, our custodial group is focused on the inside, and we'll get a handle on that. But we will be, in the future, investigating opening playscapes outside as well.
Yeah, we're taking a similar approach at this time, focusing on cleaning protocols within the school and building new routines. As we return to school, there will be different routines. So that's our focus. And as we move forward, then we'll look at those other questions, such as extracurricular activities, play structures, as we move forward.
Thank you very much. Another question is relating back to personal support workers moving between nursing homes and the putting the occupants at risk. Can we learn from this and not allow supply teachers and support staff to work in more than one school to reduce the risk?
So I can take a step from risk point of view at this question, then I turn it to our colleagues from administrative point of view. There is increased risk with any increased activity. However, the risk will never be zero. Even if all kids stayed home and we closed the schools completely, there is still potential risk for transmission because the family bubble is never 100% closed, unless people just live in real concrete bubble or to that effect. Transfer or allowing healthcare worker to work in a different facility has been recommended against. However, it has not been eliminated. There are many scenarios where you would find a facility needing extra staff from a different facility. And that has happened in many examples. The most clear examples when staff from hospitals were deployed in long-term care to support. Staff from hospitals are high-risk staff because it's hospitals, and they're deployed in long-term care. There are enough measures in place to prevent transmission, and not sharing staff is one of them. Again, it's great if we can, if there are enough teachers to do this. I'm not the best judge administratively to say it's practical or not. However, from risk point of view, it is not the end of the world if this one added layer of protection is not there.
Don't know if the board, go ahead, Ms. Wilder.
Yes, thank you. I was going to say to Dr. Aris talked this evening about all of the different measures that can take place, and Our request of our occasional staff would be, again, to do the self-screening before they come in. They look at the hand hygiene practices, everything that other staff would be doing. So we feel comfortable with staff having an opportunity to go to different schools if they need to. Dr. Ara talked about income. I know for some people, it's important that they have an opportunity to accept jobs in different areas. If they were confined to one location, it might decrease their ability to pick up jobs as well. So we want to support them in the opportunities that would be available as well.
Yeah, we would be the same, ensuring that staff do the self-assessment every morning, as all staff would do before they enter the building. The demand for supply teachers is a pertinent issue that we deal with. So we're looking at where supply teachers live and relative to the board to see if there's any adjustments that we can make. But we know that our occasional staff are an important part of the work that we do to ensure student safety. So the first step is for all staff or anyone who enters the building is the self-assessment.
And if I may, Drew, just to add to this answer, we have a novel virus that we're dealing with, and this is the word novel. It's new to many people. In public health, dealing with a pandemic with a novel virus is bread and butter. It is bread and butter. We're trained for it. We run exercises for it on an annual basis. We have pandemic plans with the counties, with most organizations have pandemic plans. And what the protocols that we use to respond to pandemics of this caliber are very similar to the protocols that we use to deal with outbreaks like influenza on annual basis many times in the year, whether it's in long-term care or schools. So there are outbreaks of influenza. I meant not pandemics of influenza. Outbreaks on annually. There are the annual flu that comes every year. It's a different virus, and the protocols are very similar. And we have dealt with it from day one in a robust way. We implemented all the measures to prevent it. Then we have had the luxury, not just dealing with a novel virus with our experience from before. We have experience with this specific virus. During the mitigation, we had full control. During the reopening stages, we maintained full control. The evidence from CDC Atlanta, again, I'm referencing that credible source, that implementing 5 measures in place would replace whole shutdown. If there is a second wave, I doubt there is going to be a second shutdown, because we know that implementing 5 measures, the 3 W's I mentioned and 2 others, washing hands frequently, wearing masks correctly, watching distance 2 meters when possible, avoiding crowds, and using the outdoors anytime we can instead of the indoors. If these 5s are in place, we would have full control over the potential transmission. So again, you go from that underlying principle or those underlying principles to focus on the question at hand. If there is a supply teacher or a teacher teaching in 2 facilities, but exercising these things, there is always going to be risk. However, it is very acceptable level of risk, and it's not much different from any risk if the kid stayed home and their parent went to the grocery store and came back. So again, to put things in perspective, this virus does not jump or have legs and wings to fly on people. It is our hands that's going to transmit it to ourselves and to our kids. And if we maintain these measures in place, I feel confident we can have safe reopening of schools for our kids.
Individual parents are having the option of opting in or opting out. What sort of considerations should they be looking at in determining what they're going to do for their children?
That's an excellent question. I'm glad it came up. I was trying to insert it in a longer question before, but I thought it's going to be too long. There are 2 sets of data sources. One of them is from public health about the epidemiology in the area. And again, this is very favorable at this point, and it might change however we provide this information to the parents. There is another set of information related to the individual themselves and the household. COVID in general in kids does not produce severe disease. If the kid has medical conditions that can predispose them to severe disease and complication, that will be an essential factor in that decision-making process. If there is a household member who has vulnerability, and whether it's cancer or lower immunity, immunotherapy, asthma, heart disease, and there's a longer list, it exists on our website or the government website. I would encourage everybody to spend 5 minutes on our website per day just to see what's new and what recommendation could be helpful with making these decisions. So if there is a condition in the household or the kid, I would strongly encourage the parent to seek assessment from the healthcare provider, the physician or the nurse practitioner who takes care of the child, or the specialist who takes care of the child, to see if this decision should be to return to school, to wait for a period of time to assess, or not to return. And again, there are many scenarios, and it's individual decision for the family. And there is no right or wrong blanket answer for everybody. It is the right decision for the family with the information at hand at that time. Our team and our website will provide all the information that you need. We will definitely provide the information about the epidemiology, and we will support the families in making that decision to the best of our ability.
Similarly, I have a question from a grandparent, and with respect to their grandchildren going to school now, how safe can they feel in their bubble?
Again, it really lends itself to the same answer. And you know, I have two parents who are older adults, and one of them has severe heart disease and some asthma as well, which makes it more complex. And when the grandkids, my nephews, will go back to school, the decision based on this information, based on the advice from their healthcare provider, is to take no risk. So the bubble should be split. Again, does this mean that they're not going to see them? Absolutely not. You can see them with some distance. You can see them behind a window. You can even get closer and have a quick hug. All in all, it's based on the need for the family, how much mental health need for all individuals, and how much risk there is from transmission for these individuals based on the conditions they have. Again, as a son of two, I have provided the recommendation in joint consultation with their healthcare provider not to take any risk there.
Thank you, Dr. Ara. You alluded to the vaccine earlier, and that was one of the questions: is where are we at with the vaccine, and perhaps how do you see COVID playing out as we reach or head towards herd immunity?
So let me split this answer into three. One, to provide some information about what a vaccine is and how it can work in the societal level. The other one is the process of developing a vaccine and approving it. And the third one, specifically what's happening with the COVID vaccine. Measles was a scary disease, as scary as COVID or even more. It claimed many lives of Canadian children. And it moved from that scenario 60, 70 years ago to the scenario that we have right now. Physicians go through their entire training and career and wouldn't see case of measles, and that's because of the vaccine. The development of vaccine is the silver bullet we're looking for in this pandemic. It's going to put the nail in the coffin of this pandemic, and I have no doubt all the efforts have been invested into this. And you can see that all the efforts have been invested because usually it takes 2-3 years to develop a vaccine. In this case, I am cautiously optimistic it will take around 1 year. And this is referenced against to CDC, Atlanta, and Johns Hopkins. And there are 3 stages for development of vaccine. There are 2 things that are essential to be in a vaccine: to be safe and to be effective. And to be safe, just, it's a matter of 3 stages of clinical trials. They have sped up to be in 1 year, not because people are cutting corners or taking risk. They're taking financial risk, these companies and the governments that are developing them, in a way that before the vaccine is proven to be effective and safe, they have started producing doses of it. So if the vaccine is not effective, all these doses going to be thrown in the garbage, and the investment financially is going to be gone. However, the rigor of the 3 stages, the first stage would be on volunteers, healthy volunteers, to ensure safety and to ensure that the vaccine would not cause harm. The second one is to ensure efficacy, and usually it's in the hundreds of patients. The third stage is to ensure safety and efficacy and see if there are side effects, and usually in the thousands. There has been about 150 candidate vaccines at this point. In the first months, there are 11, and currently there are at least 20 going into final stages, 6 in the States, or 3 to 6 in the States, going in stage 3. So with this progress, they will be available by the end of this year or early next year as validated, safe, and effective if they are successful. Then you would have 3 to 6 months for mass production distribution to the public. And this is my own bias, my own assessment based on the annual influenza that we deal with every year. There is a new vaccine produced, and it takes 3 to 6 to produce it mass production. A few candidate vaccines, to final point about the vaccine, have been very effective in producing antibodies that are neutralizing. And bear with me if I get technical. A vaccine would have a capsule of protein and lipids. And based on those proteins, you would have the body producing antibodies that sits on the capsule of the virus. Not every antibody is going to be effective in preventing the disease or the infection. It has to be neutralizing, an antibody that can sit on the busy part of the capsule of the virus, the part that allows the virus to inject its genetic material into the cell. So in the early stages of some of these candidate vaccines, there has been a proof of high level of neutralizing antibodies. Does this mean the vaccine is going to be effective by the end of the year? No. But if the result was not effective or no antibodies, that will be a failure for the vaccine, the candidate vaccine. Again, in summary, I am cautiously optimistic we're going to find this silver bullet by the end of this year or early next year.
Thank you, Dr. Ara. I think we're getting down now to the last little bit. I think I'd like to ask each of the speakers for any concluding remarks. I might note that we had a lot of operational questions, what goes on in the school. And I think both directors would agree that the schools are best able to handle those types of questions. That's why I kept the questions to the more risk assessment type of thing. But I'll ask Ms. Wilder to give her closing remarks.
On behalf of our trustees of Blue Water District School Board and our staff and students and communities, I would like to thank Public Health and Dr. Ara for this evening, this Facebook Live event. It's been very informational for all of us, and the support has been greatly appreciated. We are encouraging our families to send their children back to school. We do appreciate that it is their choice, and we do honor the choices that we make. I want them to know that we have put all of the safety protocols that have been discussed this evening in place, and we thank you again. Our website, as you had referenced, Drew, our website has a full question and answer section, which is very specific, very comprehensive, and we would direct parents there. if they have specific questions. And as well, our administrators are back in our schools now. So if parents or guardians have questions, they can call the school directly to ask any specific questions that they may want answered. So we look forward to the week of September 8th, and all of our students returning and staff as well. So thanks again for this opportunity.
Thank you, Ms. Wilder. Mr. O'Donnell?
I too want to thank Dr. Era. Dr. Era, if the collective effort of you and your staff and our whole communities has put us in a position where we don't have any active cases of COVID-19 in our counties. And that's due to the hard work of everyone. And it's allowing us this opportunity to come back to school, to fill our hallways with staff and students, and hear that excitement of the return to school in September. So I want to thank you and everyone who joined in today. Part of building confidence and moving back to school is having all the information, and you provided us with a lot of information today. And I would encourage our families, if they have further questions, to go to our website, our return to school site. With Blue Waters, it's a full site. There's a lot of information there. Some folks say there's too much information, but it's a full plan for everyone to get the information they need. But if they need any other answers, they can call their Catholic school principal and chat with them, and we'll get the answers that families need. So we look forward to September and welcoming everyone back. And again, thank you very much for the opportunity to be here tonight.
Thank you, Mr. O'Donnell, and thank you, Ms. Wilder. I appreciate both directors making themselves available for this. The final word from Dr. Era.
Thank you, Drew. I really appreciate the comments, Ms. Wilder and Mr. O'Donnell. The credit really goes to the public in doing the heavy lifting. It goes to our team in the health unit, not to myself alone. We have the ID team has been in the news in different times. The communication team, by definition, everything you see out there is the product of their burning the candle at both ends. I am very proud of being part of this team. I've never been proud of being on a team more than this one. The people who do heavy lifting also in the background that's never been mentioned, our corporate teams, the HR that have been instrumental in recruiting the specialists and the professionals that we need to tackle this emergency, beefing up the different nursing and public health inspectors team. Again, they come into the response in different ways. Sometimes it's obvious, it's not. Every nursing team that we have in the health unit, whether it's the vaccination team or other teams, have been supportive of the infectious disease team. The IT team, the finance team, the facilities team. The finance team, again, like, many people think that's the same function. Well, it's not. In the middle of emergency of trying to recruit many people, I know our managers and staff have been working around the clock to do this. All in all, thank you for your comments. I will definitely pass it to the team. And again, the main point, two main points, I should say here. There are many of them, but if I want to narrow it down to parting words to the families, this is not an easy decision that you're making. Every parent out there making the decision to send their kid to school, this is a decision that has not been made for the past 102 years. The last time we had a pandemic of this caliber was in 1918, the Spanish flu. Again, it's a very sensitive, difficult decision for some families, for all families, but it is very sensitive for some families. Collect the information that you need, depend on the facts, not the fiction. There are plenty of fiction out there. Go to our website, go to your school's website, see the plans. I am confident they're robust. The government website would provide more information as well. And we will do our best to give you the information in a timely way to make this decision. It's not going to be one day decision. It's going to be the first day, then after a week and after 2 weeks, and you're going to evaluate it as you go. We are here to support you. We will do our best to be of service. And I am confident as a group, we're going to go through this together. And the second point for parting words is asymptomatic testing. Testing everybody just because you heard of a case is not going to provide reassurance to anybody. I can test negative today, and tomorrow, the day after, I can be positive. So these measures that you will find in your school's plan on their website, on our website, how to screen your kids, how to ensure you provide them with the education to protect themselves. The 3 W's, again, these 3 W's, washing hands, wearing a mask correctly, and watching distance. If you can provide this to your kid and develop a habit, we are creatures of habit. And within a week or two after school start, if they have been mindful of it, top mind, the word mindful is to keep it top mind, it will become a habit and will protect them and protect the staff in the school, protect the community, protect your family. And again, we are here to serve and support, and our team will be glad to respond to any specific questions. At the end of this session, there will be questions there that we're going to collate and put in question answer format on our website if your question has not been answered tonight. Thank you.
Thank you very much, Dr. Ara, and thank you, Ms. Wilder and Mr. O'Donnell, for their participation today. And thank you, everyone, for joining us here on this Facebook Live. As I stated at the outset, it's been recorded and will be posted on YouTube. Additional questions, as Dr. Ara described, can be forwarded to our Contact Us page on our website. That's public health at publichealthgraybruce.on.ca. The health unit, both boards of education and the province have extensive resources available online. I urge you to consult those resources for the most up-to-date information. That information is evergreen and will be changing as the situations develop. And again, thank you very much for joining in.